going to give you a talk here that's a little bit more futuristic. There may not be a whole lot of data, not a lot of review articles, but I thought this was interesting, and it reflects a little bit about what I do. I'm a clinician scientist, or a scientist, run a research lab, and have contributed to how we move forward scientifically in several areas. We're going to talk about intraoperative neuromonitoring. Disclosures, and the main one here is I do have an interaction with neurovascular research and design that I'll speak about as we go forward with the talk, and that's just purely one of an academic activity with research and clinical trials. So the objectives is I like to present to you the rationale for doing intraoperative neuromonitoring, why I think this is important as a clinical tool. This has been invoked in other therapy, other surgical disciplines, prominently neurosurgery, but many others, general surgery, orthopedic surgery, and it's high time we consider bringing this now to radical prostatectomy. And I think it's the opportunity for us to do this technique, bring this methodology forward to inform the surgeon to take preventable actions, intervention that may actually preserve nerves. Adam, you talked about how to do the surgery better. This may be an option or a way to move that forward. And I think there are a couple very specific ways in which I think we're moving forward with the idea of intraoperative neuromonitoring and radical prostatectomy. So by way of background, radical prostatectomy and ED is well known, and certainly we know that there's success with the surgery, but it comes at the cost of the nerve injury that has to do with erectogenic nerves. We know that we've had the advancement of cavernous nerve sparing techniques, Dr. Walsh, my mentor, and that there's a rates of reducing ED. And of course, it's debatable across the literature, so I won't get into all of that. Other morbidities have been largely controlled. We do the surgery better. Patients recover faster. I got to tell you, back when I was doing the surgeries in the 80s and 90s, patients would be in the hospital for a week, be sometimes in the intensive care unit, transfusions, recovery. I mean, all that's, I think, history now. Dr. Walsh, of course, known for many quips and jokes, but also has some sage comments. Here he said, if it were possible to cure prostate cancer with surgery with few or no side effects, there would be less debate on how patients should be treated. I think that's a thought that makes some sense to all of us. I think that resonates. If we can actually do these surgeries better and reduce the risks, I think more men would conceivably move forward. Now, this summarizes a bit some of the early work from Dr. Walsh. He'd like to say it's more than just nerve sparing, just doing the surgery better anatomically with various respects of understanding the vasculature, the perivesical, periprostatic fascial structures, the anatomy of the sphincter and the pelvic floor. So all of these sort of things have translated into surgical outcomes that I think have allowed us to do better surgeries. And certainly there have been many other contributors to the field as well. And I think this slide nicely shows a little schematic from the Campbell-Walsh Urology of how we think of the neurovascular bundle, posterolateral to the prostate here, kind of seen in this coronal view, heading toward the urethra, also toward the prostate area. And this is what we've conventionally thought about where the neurovascular bundle runs. We use this term neurovascular, and Dr. Walsh likes to say that had to do with us understanding the anatomical landmarks. And just a quick slide here, Kaplan-Meier curves. You've seen a few of these. I thought I'd throw one in here for those who are the oncology purists. But here he just, with his early data, like to make the remark that with these various outcomes, whether you did nerve sparing or not, the outcomes are very similar across the line of these various outcomes in terms of the pathology findings. Now, the idea here is that the neurovascular bundle is thought to be posterolateral, but more recent anatomical studies by many different investigators, Costello, Takanaka, and others, Tawari, have certainly described that the distribution of the cavernous nerves is much more than where the neurovascular bundles run. And that has led to ideas to revise the surgery. Now, all of this has come about in the past 15 years or so with the notion that if we doing these surgeries well based on anatomical principles, why are we not getting better outcomes? And I think the answer may well be that the nerves may be more dispersed than we think they are. And then you can see from the slide there's various descriptions of interfascial, infrafascial techniques and so forth. But have these outcomes really delivered is the question. Of course, we've had robotic prostatectomy, and no time to get into great details of that during this talk other than to say that I think this is where we are now, and this is where we can offer surgeries to patients with various advantages. There may be some minor disadvantages here, depending on how you look at it, but nonetheless, this is where we are to carry out this operation. We know that even when we do nerve sparing, there's risk of injury to the nerves along the lines of various scientific kind of principles, ideas here, and you can read from the slide. Just even if we do the nerve sparing well, the nerves can have trauma to them. And of course, there's a science and a field that's moved afoot to try and understand how we can better preserve nerve function. And that may be another concept for consideration as well. And this slide just makes the point that it's not all on us as surgeons, right? I mean, we all realize this. There are various factors that have to do with why patients have erectile dysfunction in the setting of prior radical prostatectomy. It's not just the surgical aspects, but various other aspects, psychosocial, health comorbidities, and so forth. And we're all familiar with all of that. The nerve injury, just get back to that, may also have to do with not just the principles of nerve degeneration, but also the reality that the nerve complexity, I think, is very variable in all patients. And I think we're starting to understand that. And if we can get our handle on that, I think that will advantage us as we go about doing these surgeries better. Here's some basic concepts for preserving sexual function. How do we do the surgery well and better? How do we treat ED, okay, that occurs in the setting of prior prostate surgery or pelvic surgeries? And with some ideas, okay, listed toward the bottom of promoting erectile function recovery. And I can tell you in the sexual medicine conferences, we can have whole day conversations on any one of those three things at the bottom. And we're not going to get into all that, but just give you kind of a broad scope of where I think we do have some opportunities to try and make some impact. The focus of this talk really is how do we do a better job of doing the surgery? How can we preserve the periprostatic structures, the cavernous nerves, and considering mapping techniques and ways to do the preservation? And I'm going to tell you how we're moving forward with that with intraoperative neuromonitoring. Now, I briefly mentioned before that I think we have had a better understanding with some very good neuroanatomical dissection work that has been carried out by a number of investigators. That this concept of this neurovascular bundle, and that's all it is, I think we need to kind of move away from that understanding. It's a much more complex anatomy than that, and it's variable between patients. And while there may be a general notion that there's a spray-like distribution representing the outflow from the pelvic plexus, and that's at the base of the prostate, then there's a coalescence of nerves, and then another spray-like pattern toward the apex of the prostate. And in general, that happens, but it's still much more variable than that, and that alone may not be all that there is. I just throw this slide in with some of the work that we did in our laboratory. We did these big cross sections through the pelvis in situ to try and understand that there is a great nerve distribution shown over here, but these are different nerve stains, and I won't mention the details of that, but it's really a complexity of these nerves and really understanding where they are. But the next thing is, how can we understand which are really the functional nerves, not just all nerves? And I'm going to tell you a little bit more about how we figured out some of that. Now, there have been methods that have been put forward in the literature for mapping the cavernous nerves. And you can see from the slide here, we have the electrical nerve stimulation. That's really been the conventional technique that dates back to Tom Liu and others who described how you can go about trying to understand the nerve distribution in the pelvis, optical neurostimulation, fluorescence, and various other kinds of imaging techniques, and all have their strengths and there's various limitations. Can we use these intraoperatively is a question. And of course, with the electrical nerve stimulation, everyone may recall the cavern map that was used, and this really everybody was excited to use about 15, 20 years ago, and it fell out of vogue because it had really poor results in terms of how you can really identify the nerves or predict outcomes, and that may have to do with poor spatial specificity, poor contact in the pelvis, and perhaps even the opposing effect of stimulating sympathetic nerves that are anti-erectile. So all of these are factors that have not lended us to really make great advances despite all these techniques that have been brought forward. I was intrigued by some of the work by Takanaka and others from Japan who'd done some great work going back now 15, 20 years, really helping us understand that using electrophysiologic studies to try and map the nerves in the pelvis has led to some discovery work. And what he's trying to show here is that here's the prostate, here's the levator ani looking in a retropubic view, here's a cadaveric section looking at it laterally, and really stimulating in different locations and even posterior to where we think the neurovascular bundle can elicit electrophysiologic responses. Again, this just makes the point that the nerves are locations we don't always expect that they would be. The problem with these kinds of techniques is you're just subjectively just saying, where do I think the nerves are going, to try and figure out what's going on. And that may not be good enough to understand the full topography of the cavernous nerves. There are new cavernous nerve mapping techniques in combination with neurostimulation I think will be exciting based on some preclinical work where we combine electrophysiology with real-time imaging that I think may give us a better perspective on where all these nerves are. And this is an article we did a little while ago that put together some of the various techniques, but using a multimodal approach may actually give us both the anatomy and the physiology and really understand which nerves are the relevant nerves. Here's an example here in a rat study we did where we actually did voltage sensitive dye testing. So actually you put an electrode in the pelvis, stimulate the nerves. It leads to depolarization of the nerves coming through the pelvic area. And with selective voltage sensitive dyes, you light up the nerves that are actually erectogenic. Isn't that amazing? So if we can actually do that in the human and actually see where these nerves are that are selective for really the ones that fire to govern penile erection, that might be a real tool to consider. Here's another one we did in which we actually looked at the subset of nitric oxide nerves, and a field that I've worked on for 30 years now, nitric oxide and penile erection. And it's not just the total neuronal nitric oxide synthase nerves, it's the ones that get phosphorylated or activated that are really true for erection. And what we're showing here is in a rat study that the phosphorylated nNOS nerves versus the entire nerve staining, that these are selective nerves, that if we can identify those would be most important to preserve. And why is that important? Because there's a lot of literature out there that says, well, there's neuronal NOS nerves throughout the pelvis. If we just spare all of them, they're going to do a great job, some running anteriorly and even into the prostate. Well, are those really the nerves that are relevant? And I think if we can bring these kind of techniques to the clinical level, that would really advance the field. So what about artificial intelligence and kind of a pivoting a little bit? What we know that this is obviously really an advance in science in our field, in medicine in general. A set of mathematical algorithms, computer programs, machine learning, a subset of that to improve our performance on specific tasks. Can we bring this to radical prostatectomy? Well, it has various potential roles just shown here in urology potentially. Can we do it for prostate cancer surgery? Here, machine learning with the idea here of various kinds of areas of investigation, experimental, biological, radiologic, clinical data sources that we plug into a system that trains a machine learning algorithm whereby you can develop your observations and develop a model where you can develop ways in which we can then output this and carry out or execute performance characteristics that may be better than we're doing just on our own. So this is an idea here, and in fact, this is how we think we can bring this to what we're doing. So what we're doing here is to create a real-time automated method with self-learning, machine learning, with real-time feedback capability for the surgeon to be able to be trained and then carry out the operation better. And so this is a nice I'm gonna spend a moment on this diagram that puts it all together. So on this side here are the various kinds of sensors and electrodes that we're putting into the patient as we start the operation. We can actually then record from it. We can do a way of creating neurostimulation, which we do with sacral-level stimulation, which is parasympathetic. And I'll tell you about how we're doing that in a moment. This gets recorded using various grids that we put in the pelvis, and we're actually designing various grids that can overlay the prostate and the pelvic floor, pick up signals at the beginning of the case, input it to the software, train the software to pick up the signals that will guide the surgeon, conceivably with virtual grids that will design to go over the top of the prostate as you're doing the operation. So all of this then is then how it's put into a kind of a software program. It would teach the surgeon as he's going about the surgery to take auditory or visual signals as you're executing the surgery that tell you where the nerves are. And that's kind of where we're going with this concept. We've developed a technique now. Neurovascular Research and Design has designed specialized spinal electrodes that can be placed at the lumbar spine level, but find its way to sacral levels 2 through 4, which are selectively the parasympathetic nerves. These are the proerectile nerves. Then once stimulated with a remote controller, can then drive neurostimulation through the pelvis, cause firing of the cavernous nerves, and elicit penile erection simultaneously. And we've been able to do that fairly consistently now with some of our early studies. This is an example here, another schematic of a patient. After you actually start the surgery under anesthesia, do the spinal electrodes, turn the patient back over, You can place various kinds of sensors, such as the near-infrared spectrophotometry on the penis, a urethral catheter that can pick up signals at the level of the sphincter. And then you have off to the side various other techniques here where you have handheld probes and software that can actually evaluate under stimulation what are the responses as you're carrying out the operation. So we've done some of this and are presenting some of this at the upcoming AUA meeting. This is just a brief description. I won't read it all, but just in a few early patients now, pilot studies, we've been able to do this both with open surgery and robotic surgery, and showing that we can actually determine a true grid pattern of the action potential amplitudes that overlay the prostate going towards the lateral aspects of the prostate. And we can do this real time and continuously throughout the entire operation. So this is just a brief example of an open surgery where what's shown here is the left and the right side continuously at different time points throughout the surgery with specific moments just recorded here in these tables with where you're executing the surgery, baseline, after dissecting pedicles, taking the prostate out and so forth. And what we do is with these, our early stage grids, we can actually create channels that with the sacral-level stimulation, you can actually pick up nerve signals and map out where these nerves are overlying the prostate and off to the pelvic sidewall. And we also have these grids that we're developing for the robotic cases as well. And again, the idea is placing them at the beginning of the surgery, letting the software record the results, remove the physical grid, and then as we're developing the software and input enough patients that can actually train the computer to pick this up, then translate that back over. And the idea is we eventually want to develop this where we have virtual grids whereby the surgeon, while executing the surgery and continuous neuromonitoring, can pick up either with auditory or visual signals where you are actually connecting or injuring or irritating the critical nerves that are picked up with the sacral nerve stimulus. So that's really kind of where this is all going. And this is just an example here with the electromyography for the external urethral sphincter that you do pick up signals with a urethral catheter that can actually pick up these nerve signals as well at the level of the external urethral sphincter. So during the dissection of removing the prostate, you can actually pick up signals at that level as well. So that tells us there is some autonomic innervation of the sphincter. It's not entirely somatic. There is some autonomic innervation there. So the idea here is we're going to continue with now a larger study. We're probably going to involve a couple institutions as well, probably later this year, to carry out these operations with this technique, and then hopefully bring this forward as a technology for neuromonitoring that can be adopted and used in a practical way while executing surgeries. So we do think that this is kind of an exciting new technique, a little futuristic, and I think it's going to evolve here, but I think this may be a way for the future, that with the execution of the surgery, we can localize the nerves. We have various imaging techniques I think we will be able to bring forward from a preclinical to clinical level. I think we're going to use intraoperative neuromonitoring to help us do these surgeries better. But I think it's intraoperatively, there are other techniques that may be brought simultaneously to the surgery. Postoperatively, there's various other techniques as well. Another very exciting technology we're working on right now is implantable neurostimulators. That's another talk where we actually are putting stimulators in the pelvis just after getting the prostate out, and early postoperatively with remote stimulation, we can actually elicit nerve firing and regenerate these nerves. And these guys are getting their erections back within 1-2 months after radical prostatectomy, which is very exciting too. So we'll be talking more about that with some studies to come as well. So by way of conclusion, sexual dysfunction may still be the final frontier. I think it has to do with, while we think we're doing these surgeries well, based on anatomical principles, we can still do it better based on technology that's based on good scientific evidence, anatomically and physiologically, and we can do a better autonomic nerve preservation. And so I do think this may be options for the future to improve still both erectile and urinary function. And certainly maybe I can come back and tell you where we are in a couple of years while I think we get this further advanced. But we're excited about it, and we think this may be something that will improve our outcomes. So I appreciate your attention. I'll stop there. Thank you.